Globally, anemia affects 1.62 billion people, which corresponds to 24.8% of the total population. The highest prevalence is in preschool-aged children with a rate of 47.4%, and the lowest prevalence is in men with 12.7%. However, the population group with the greatest number of individuals affected is non-pregnant women, with a total of 468.4 million. Anemia is a decrease in RBC and hemoglobin, resulting in decreased oxygen delivery to tissues. If you have anemia, your blood does not carry enough oxygen to the rest of your body. The most common cause of anemia is not having iron. Your body needs iron to make hemoglobin. Hemoglobin is an iron-rich protein that gives red color to the blood. It carries oxygen from lungs to the rest of the body. For adults, World Health Organization defined anemia as a hemoglobin level lower than 12 grams per deciliter in women and 13 grams per deciliter in men. But the reference values for red cells, heme or hemoglobin, may differ according to sex and age, race, altitude, socioeconomic changes, and reference. Note that different red cells, measures of the same nation, may give discordant values in special conditions, like having low heme and MCD but high RBC. An example of this is the thalassemia trait. Let's discuss about the two tissue complexes that anemia leads to. The two tissue complexes are tissue hypoxia and compensatory attempts. So first, let's discuss about the tissue hypoxia. Tissue hypoxia caused by the reduced levels of heme results reduced oxygen delivery to the tissues. The symptoms and findings of anemia concern many different systems or organs due to widespread nature of hypoxia. Example of these is fatigue and dyspnea on exertion. The second tissue complex is compensatory attempts. The example of these is tachycardia and hyperventilation. So now, let's have a brief discussion about the clinical symptoms and findings of anemia. So we have the fatigue or weakness and pallor. So in fatigue, it includes tiredness and reduced exercise tolerance, and also the generalized muscular weakness. In pallor, skin color may change due to other reasons. For examples, blood flow of skin, subcutaneous fluid, and pigment changes. Pallor is also known as paleness. In pernicious anemia, there is a lemon yellow pallor. Pallor plus escleroterus suggests hemolytic anemia. Pallor plus beta shade suggests severe bone marrow failure. For the continuation, let's discuss the clinical symptoms and findings of anemia in the different systems in the body. So, let's talk about the reproductive system. In reproductive system, there's menstrual changes, amenorrhea, menorrhagia, which is the mostly cause of anemia. For renal changes, we have slight proteinuria, concentrating defects, for the reduction of renal function in patients with previous renal impairment. Renal failure itself is a cause of anemia. For the highlight of our discussion, we are now going to talk about the classification of anemia. We have the morphologic and the pathogenic. In morphologic, we have the normocytic, the macrocytic, and the microcytic. In pathogenic, or the underlying mechanism, we have the blood loss or bleeding, decreased RBC production, and increased RBC destruction or pooling. So now, let's proceed to normocytic anemias. Under normocytic anemias, we have the acute post-hemorrhagic anemia, hemolytic anemia, and note that the thalassemia and other
have the iron deficiency anemia, thalassemia, sideroblastic anemia, lead poisoning, anemia of chronic diseases, megaloblastic and non-megaloblastic anemia. In megaloblastic macrocytic anemias, we have the vitamin B12 deficiency, folic acid deficiency. So now, let's proceed to the highlight of this topic, which is the classification of anemia. We have the morphologic, the pathogenic, and the degree of hemoglobinization. So now, let's have first the morphologic. Under the morphologic, we have the normocytic, microcytic, and the macrocytic. Under the degree of hemoglobinization, we have the normochromic and then the hypochromic. Lastly, we have the pathogenic or the underlying mechanism. We have the blood loss or bleeding, decreased RBC production, increased RBC destruction or the pooling. And now, a brief discussion under the morphologic classification of anemia. We have the microcytic hypochromic anemia, macrocytic anemias, and the normocytic anemias.
In macrocytic anemias, it is often stem from abnormalities that impair the maturation of erythroid precursors in the bone marrow. Normochromic diverse etiologies. In some of these anemias, specific abnormalities of red cell shape provide an important clue and is least appreciated through visual inspection of peripheral blood smears. In general, we have microcytic hypochromic anemias, microcytic anemias, and normochromic normocytic anemias. Microcytic hypochromic anemias is the disorder of hemoglobin synthesis. It is most often seen in iron deficiency.
So now let's discuss about the normocytic anemias. Under the normocytic anemias, we have the acute post-hemorrhagic anemia, hemolytic anemia, the thalassemia and other disorders are the exemption. Aplastic anemia, pure red cell aplasia, bone marrow infiltration, endocrine disease, renal failure, liver disease, chronic disease anemia, protein malnutrition, and hypovitaminosis C. Now let's proceed to the microcytic anemia. We have the iron deficiency anemia, thalassemia, sideroblastic anemia, lead poisoning, anemia of chronic diseases, megaloblastic, and non-megaloblastic. In non-megaloblastic macrocytic anemias, we have the anemia of acute bleeding, hemolytic anemia, leukemias, liver disease, aplastic anemia, alcoholism, hypothyroidism, and scurvy. And now for the pathogenic classification or causes of anemia. We have the relative or increased plasma volume, decreased RBC production, blood loss, anemia due to acute bleeding, increased RBC destruction, decreased heme production, which is the iron deficiency anemia, thalassemia, sideroblastic anemia, lead poisoning, and the defective DNA synthesis, which is the vitamin B12 deficiency and the folic acid deficiency.
Pluripotent stem cell defects. We have the aplasia anemia and the leukemia. Next, defective erythroid stem cell. We have the pure red cell aplasia, anemia of chronic renal failure, endocrine disease anemia. Hemolytic anemias are anemias caused by increased RBC destruction. Can be classified as hereditary hemolytic diseases, acquired hemolytic disease, intravascular hemolysis, and extravascular hemolysis.
Anemias of blood loss. Acute blood loss. The effects of acute blood loss are mainly due to the loss of intravascular volume, which is massive, can lead to cardiovascular collapse, shocks, and death. Significant bleeding results in predictable changes in the blood involving not only red cells, but also white cells and platelets. The chronic blood loss. Chronic blood loss induces anemia only when the rate of loss exceeds the regenerative capacity of the marrow or when iron reserves are depleted and iron deficiency anemia appears. Hemolytic anemias. Hemolytic anemias share the following features: a shortened red cell lifespan below the normal 120 days, elevated erythropoietin levels and compensatory increase in erythropoiesis, accumulation of hemoglobin degradation products that are created as part of the process of red cell hemolysis. Hemolytic anemias are extravascular hemolysis and intravascular hemolysis. Extravascular hemolysis is generally caused by alterations that render the red cell less deformable. Extreme changes in shape are required for red cells to navigate the splenic sinusoid successfully. Reduced deformability makes this passage difficult, leading to red cell sequestration and phagocytosis by macrophages located within the splenic cords. Regardless of the cause, the principal clinical features of extravascular hemolysis are anemia, splenomegaly, and jaundice. Some hemoglobin inevitably escapes from the phagocytes, which leads to variable decreases in plasma haptoglobin, an alpha-2 globulin that binds free hemoglobin and prevents its secretion in the urine. Because much of the pathologic destruction of red cells occurs in the spleen, individuals with extravascular hemolysis often benefit from splenectomy. Less commonly, intravascular hemolysis predominates. Intravascular hemolysis of red cells may be caused by mechanical injury, complement fixation, intracellular parasites, or exogenous toxic factors. Causes of mechanical injury include trauma caused by cardiac valves, thrombotic narrowing of the microcirculation, or repetitive physical trauma. Complement fixation occurs in the variety of situations in which antibodies recognize and bind red cell antigens. Toxic injury is exemplified by clostridial sepsis, which results in the release of enzymes that digest the red cell membrane. Hereditary spherocytosis. Hereditary spherocytosis is an inherited disorder caused by intrinsic defects in the red cell membrane skeleton that render red cells spheroid, less deformable, and vulnerable to splenic sequestration and destruction. Sickle cell disease. Sickle cell disease is a common hereditary hemoglobinopathy caused by a point mutation in beta globin that promotes the polymerization of deoxygenated hemoglobin, leading to red cell distortion, hemolytic anemia, microvascular obstruction, and ischemic tissue damage.